Hello everyone, welcome to Prosto Hub. Myself Dr. Julesna, and today we are going to discuss the second session of the topic Diagnosis and Treatment Planning in Implant Industry. So in our previous session we have discussed the history regarding the extraoral and intraoral examination, radiographic examination, the bone density classification and assessment of bone, and also the positional guidelines for implant placement. And the next topic to be discussed is diagnostic cast and surgical templates. So before getting into detail, I request everyone to please do like and share my videos if you're finding these videos useful. And if you're new to this channel Prosto Hub, please do subscribe and support me. If you have any queries, feedbacks or topic suggestions, you can either comment below this video or you can mail me at this mail ID. So let's get into the topic. Now we know that the diagnostic cast or the study model is important in all phases of dentistry, especially in oral implantology. So this should be the first step in the process of treatment planning for dental implants. And diagnostic cast should be accurate reproduction of the maxillary and mandibular arches, and we have to mount these diagnostic casts in order to get the accurate maxillomandibular relationship. So what are the uses of these diagnostic casts? So these are used for initial evaluation of the implant site selection, angulation requirements, prosthesis selection, existing occlusion, fabrication of surgical template, that is diagnostic cast. When after mounting we do the diagnostic wax up, and these final diagnostic casts are duplicated to fabricate surgical templates. And also this allows for a pre-operative assessment of the various treatment options that we can discuss with other practitioners or laboratory technicians, and also patient consultations. So these are the uses of diagnostic cast. Next, coming to surgical templates or surgical guides. So we have already discussed about radiographic template in our previous session. So what are these surgical templates? So these are fabricated after the diagnosis and prosthetic planning. So let us see the requirements of a surgical template. So a surgical template should guide the surgeon for precise positioning and angulation of the implant in relation to the remaining natural dentition as well as the residual alveolar ridges. Next, it should be stable and rigid when positioned in mouth, and they should be easy to place and remove. It should not be bulky and should not interfere with the tissue reflection or visualization of the surrounding landmarks. Also, it should be transparent and should allow for easy access for the surgeon, especially in the posterior region. And it should be sterilizable in order to ensure surgical asepsis. Usually, we disinfect the surgical template with 3.2% glutaraldehyde and then immerse in 2% chlorhexidine during the surgery. And the template should also be reusable for a number of procedures. Next, let us see the fabrication of surgical template. Now, the surgical template fabrication involves a diagnostic tooth arrangement which can be made with a diagnostic wax-up or a trial denture teeth arrangement, or by duplication of pre-existing dentition or prosthesis, or we can convert a radiographic template into a surgical template. And the materials used for making a surgical template are clear thermoform to form clear vacuum form matrices, and also auto-polymerizing acrylic resin and light polymerizing composite resin matrices with metallic guides that closely match diameter of the drills or implant sizes. And these guides are fabricated with the help of CAD/CAM technology. And based on the amount of surgical restriction, there are three types of surgical template design. That is a non-limiting, partially limiting, and completely limiting design. Now let us see one by one. One is the non-limiting design. So this allows for generalized location of ideal implant site, but not about the mesiodistal angulation of the drill. So there is too much flexibility in the final positioning of the implant. And here a guide pinhole is drilled through a clear vacuum form matrix which indicates the optimal position of the dental implant. And this can result in unacceptable placement of the access hole or unacceptable implant angulation. So these non-limiting design templates can serve as imaging indicators during the surgical phase of implant placement. One is the partially limiting design, which incorporates a guided sleeve or a slot that allows for angulation of one drill size, that is usually the pilot drill. And once the pilot drill is completed, then the osteotomy and implant placement is done freehand. And in this technique, usually we make use of a radiographic stent, which is then converted into a surgical guide template. So the placement accuracy depends upon the operator. And here holes are placed on the occlusal surface of the denture tooth, which are used as slots. Last one, the completely limiting design. So here we can limit the position, angulation and depth of the osteotomy. That is, there is restriction buccolingually and mesiodistally with the help of guided tubes or sleeves. And here we can add drill stops, which limits the depth of the preparation, and thus we can avoid over preparing the site. So drill stops are protective collars that are placed around a drill bit, which are used to limit the drilling depth. And here the final position of the implant can be accurately known before the actual surgery. And so this technique is popular because the prosthetic final abutment or the provisional restoration can be prefabricated for immediate provisionalization after implant placement. So there are two designs in this completely limiting one. That is, one is cast based surgical guide and CAD/CAM based surgical guide. Let's discuss about the stress treatment theorem. So in implant biomechanics session, we said that when implants or teeth are subjected to repeated occlusal loads, microscopic stress fractures, work hardening and fatigue may result. And unlike the natural tooth system, the implant components cannot adjust or repair to these conditions, which results in fracture. And most common causes of implant related complications are centered around the biomechanical stress, which can result in many complications like porcelain fracture, unretained cemented restoration, screw loosening, framework fracture, abutment screw fracture, crestal bone loss, implant body fracture, etc. So, the overall treatment plan should assess the greatest force factors in the system and establish mechanisms to protect the overall implant bone prosthetic system. That is, we have to find the ways to decrease the biomechanical stress in order to minimize the risk of implant system complications. Now, the stress treatment theorem developed by Mish states that almost all treatment related to the science of implant dentistry should be centered around the biomechanical aspects of stress. That is, understanding the relationships of stress and related complications provides a basis for a consistent treatment system. And thus, the stress treatment theorem has evolved into a particular sequence of treatment planning that includes prosthesis design, patient force factors, bone density, the implant position, number, size, the available bone, implant design, etc. So this is the sequence of treatment planning as per the stress treatment theorem. So here first we have to determine the prosthesis design. So the final result of the prosthesis should be visualized before the selection of the implants. Next, the patient force factors should be assessed, which includes bruxism, clenching, tongue thrust, crown height, masticatory dynamics, arch location and opposing arch. So the forces applied to the restoration differ by their magnitude, duration, type and predisposing factors, which we have discussed in detail in our implant biomechanics session. Next is the bone density. We have to assess the density of the bone. We can refer the bone density classification by Mish. So, denser the bone, stiffer is the bone and there is less biomechanical mismatch to titanium during loading. Next, coming to the implant position and number. So, the in any prosthesis, implant position are more important from a stress management perspective, and we know that cantilever are a force magnifier. So our implant position should aim at the elimination of cantilevers whenever possible, especially when other force factors are increased. And we know that increasing the number of the implant increases the overall surface area and thereby helps in reducing the stress to the implant system. The implant size, again we have discussed it in our implant biomechanics session. The wider root form implants have got a greater area of bone contact than narrow implants, resulting from their increased circumferential bone contact area. So the increase in diameter not only decreases stress but also decreases the likelihood of implant fracture and also reduces forces to the abutment screw. But we cannot use implants that are wider than 5 mm, which is due to the stress shielding effect. We have already discussed it in our implant biomechanics session. Next factor is the available bone. So if available bone is not present, then bone augmentation or modification is required. And finally, the implant design. So implant macro design also affects the surface area, and a cylindrical implant provides 30% less surface area than a conventional threaded implant of same size. So we have to consider the implant design, and we can modify the implant design to increase the surface area and thereby decreasing the overall risk to the implant interface. So these are the sequence of treatment planning as per the stress treatment theorem. Next, coming to the various implant processes design. So based on design, the implant processes can be classified as fixed processes and removable processes, and based on the retention, they are screw retained, cement retained and attachment retained processes. Now let's see one by one in detail. So in 1989, Mish proposed 5 prosthetic options for implant dentistry. So first 3 options are FPs, that is fixed processes, which may be cemented or screw retained, and here the patient is unable to remove the prosthesis. And the next 2 types are removable prostheses, which depend upon the amount of implant support, retention and stability. So let us see the FP1, which replaces only the crown and appears like a natural tooth. FP2 replaces the crown and a portion of the root, and crown condor appears normal in the occlusal half, but it's elongated or hypercondored in the gingival half. Again, FP3 replaces missing crowns and gingival color and portion of the edentulous site. And RP4, mainly it's an overdenture completely supported by implants. RP5, it's an overdenture supported by both soft tissue and implant. Now let's see in detail. The first one, the FP1, where we replace only the anatomical crowns of the missing natural teeth. So here there is minimal loss of hard and soft tissue, and the volume and position of the residual bone should permit ideal placement of the implant, that is similar to the root of a natural tooth. And here the final restoration looks very similar to the traditional fixed prosthesis that is used to restore or replace the natural crowns of teeth. And usually this is indicated in the anterior region, that is in the aesthetic zone. One, the FP2 prosthesis, which restores the anatomical crown and a portion of the root of the natural tooth. So here the crown contours appears normal in the occlusal half, but it's elongated or hypercondored in the gingival half. That is, FP2 prosthesis has longer clinical crowns than healthy natural teeth, and patient and clinician should be well aware of this fact from the onset of treatment. And the volume and topography of the available bone are more apical compared to the ideal bone position, that is around 1 to 2 millimeter below the cemento-enamel junction. And an FP2 fixed prosthesis appears like a natural teeth which exhibits periodontal bone loss and gingival recession. This is the FP3 prosthesis, which replaces the natural teeth crowns and has pink colored restorative materials to replace a portion of the soft tissue, especially the interdental papillae. So this replaces the crown, a root and a portion of the gingiva, and this is specially indicated when there is increased bone loss and there is a necessity to restore gingiva in the proposed implant site. So when there is a case when patient is having a high smile line and the cervical area is visible, then in that case we can opt for an FP3 prosthesis rather than FP2 prosthesis, because FP2 are having elongated crowns, so will have an unaesthetic appearance. So in such cases you can opt an FP3 prosthesis. And there are 2 basic approaches to the FP3 prosthesis. One is the hybrid restoration or hybrid prosthesis, which is made up of acrylic resin teeth and denture base, and then the porcelain metal restoration, where the metal is fabricated with tooth colored and gingival colored ceramics. And another advantage of this prosthesis is that the implant does not have to be along the long axis of the tooth, and it allows for mesiodistal flexibility in implant placement. RP4, which is a removable prosthesis, completely supported by the implants, teeth or both. So usually it is a overdenture supported completely by implant with a superstructure bar. So the restoration is rigid when inserted and there are attachment which connects the removable prosthesis to the superstructure that splints the implant abutment. And here the patient is able to remove the implant prosthesis but not the superstructure attached to the abutment. And these overdenture attachment permits improved oral hygiene and also allow the patient to sleep without the excess forces of nocturnal bruxism on the prosthesis. And again, the implant placement criteria for an RP4 is different from that of a FP. So here we have to consider more prosthetic space for the denture teeth, acrylic base, and also we have to add superstructure and overdenture attachments. So in such cases, it requires more lingual and apical implant placement compared with that of the fixed prosthesis. Finally, the RP5, which is a removable prosthesis combining implant and soft tissue support. So here usually it is an overdenture supported by both soft tissue and implants. It may or may not have a superstructure bar. So usually in maxilla, 4 implants are required for a successful implant supported overdenture, whereas 2 implants are sufficient for a similar processes in the mandible. So the primary advantage of an RP5 restoration is the reduced cost because fewer implants are inserted compared with that of a fixed restoration. And here the prosthesis is very similar to traditional overdentures supported by natural teeth. And another thing to note is that in an RP5 restoration, relines and occlusal adjustment are required every few years because the bone will continue to resorb in the soft tissue bone regions of the prosthesis. Next is the prosthesis design based on retention. So there are three types: the screw retained, cement retained and attachment retained prosthesis. Coming to the screw retained prosthesis, where the restoration is screwed into the implant, and here a hole is present in the restoration where we fit the screw, and this hole is usually filled with composite that blends with the restoration. And the advantages of screw retained restoration is easy retrieval is possible. It can be used in limited interocclusal space. So in case of a cemented prosthesis, we need a vertical component of around 5 mm or more to provide adequate retention and resistance. Whereas screw retained restoration require low profile retention and so it can be used in limited interocclusal space. And here there is better tissue response when compared to cement retained restoration. Coming to the disadvantages, ideal implant position is required for a screw retained restoration and the restoration should be passive. So if it is not passive, then the forces of the prosthetic screws are transmitted to the implant bodies, which can result in porcelain fracture, screw loosening, etc. And usually there is a difficult access in screw retained restoration, especially in the posterior region. And this is relatively expensive because of its components. So the screw retained prostheses are indicated in case of minimal inter-arch space, fixed danger prostheses with a cantilever design or long span FTPs, because these two situations have got higher risk of complication and they require more maintenance and service. And to avoid an additional risk factor of the use of cement and possible cement remnant which can cause peri-implantitis, and screw retain process is also recommended for the aesthetic zone for provisionalization of implants to enable soft tissue conditioning and finalization of the emergence and mucosal profile. This is because it simplifies the technique and can be removed whenever needed. And then when retrievability is desired, we can prefer screw retain restoration. But one thing to take care is implant must be placed in a prosthetically ideal position with the screw hole of the plant crown below the plant incisal edge in order to facilitate screw retention. Next is the cement retained restoration, where the restoration is cemented or bonded to the abutment just like a conventional crown is bonded to the tooth. Coming to the advantages, so here there is flexible implant positioning. So there is no screw or screw hole. So there is flexibility in implant positioning. And we can also adjust the occlusion and occlusal contacts more easily than a screw retained one. And it is easily accessible and relatively less expensive compared to that of a screw retained restoration. The disadvantages include retrieval is unpredictable. So cemented fixed processes can be retrievable when a soft access cement is used as a luting agent. And we need a minimum of 5 millimeter of abutment height for adequate retention and resistance form. And also the excess cement or the residual cement leads to peri-implantitis and poor tissue response. Coming to the recommendation for cement retained restoration. So they are used for short span prosthesis with margins at or above the mucosa level. So usually if it's a bone level implant, we prefer screw retained restorations because it allows for soft tissue conditioning and also the development of proper emergence profile. And then improperly inclined implants. So one of the important advantage of cement retention is that it compensates for improperly inclined implants, and also it is easy to achieve passive fit due to the cement layer between the implant abutment and reconstruction. And again, cement retention is indicated in cases where an easier control of occlusion without an access hole is desired. So because there is no access hole, there is an intact occlusal table, and so it's easy to control the occlusion and occlusal contacts, especially in posterior sites with narrow diameter crowns. So one of the most important steps in treatment planning of an implant restoration is to choose between screw retained and cement retained restoration. So here you can see a flow chart that illustrates the pathway of decisions regarding which retention type to select. So as we have already said, in anterior, if it's a bone level implant, you can go for a screw retain if the implant is properly positioned. If a soft tissue level implant and it's placed malpositioned, then you can go for a cement retain. And if there is inadequate interocclusal space, you can go for screw retain. And in posterior region, if implant properly placed, then screw retain. If it's malpositioned or if it need occlusal adjustment, then you can go for a cement retained restoration. Finally, the attachment retain prosthesis. So numerous attachments like locator, ball, bar, etc. are manufactured by the implant companies to retain the implant supported removable prosthesis. So I'm not going into detail of these attachments. If you want to know about this in detail, please do comment below this video. Next, coming to treatment planning and methodology, which we will be continuing in our next session. Thank you everyone for watching this session, and if you have liked this video, please do click the like button and share my videos. If you are new to this channel Prosto Hub, you can subscribe Prosto Hub and support me. If you have any queries, topic suggestions or feedbacks, you can either comment below this video or you can mail me at this mail ID. So it's a bye from Prosto Hub until our next session.